I was first worried about her being on her own as a single mother, but then somehow I transferred my worries to myself. If something happens to Craig, how am I going to keep myself together? So somehow the anxiety turned into depression, which I have no idea how, but it turned out my depression got more severe. So when I went to MCV, I was not eating, thought I would contaminate the bathroom, didn't want to clean my teeth, take a shower.
She just was not herself. She'd become somebody different.
I lost weight to the point of being 80 pounds, is that?
She went down 25 pounds or more in less than 2 months. But I remember after either the first or second, very early on, it was late in the morning when she got the treatment. I helped her and a nurse helped her back to her bed, and someone had brought lunch, and it was sitting there on a tray. And here she had fought eating anything substantive for weeks. She sat down and she devoured a sandwich, and she said, "That was good." And I thought, whoa. Things are beginning to change, and they changed pretty rapidly after that.
So I formed a quartet recently within the last year, and we play classical music together, and the other thing that keeps me playing is the Scottish fiddling. I go to the recreation center where I'm planning to go today later. And so this is my shirt. I can show you my shirt. It says, "Get wrecked." I go and I get wrecked at the rec center basically every day.
At every level, I was just so impressed with how it functioned. So that care meant a great deal to me, of course, to both of us. And so soon after she got better, came home, we started to say we really need to do something.
It makes us feel good to say thank you right now.
Good evening. I'm Margaret. Go ahead and clap. I'm sorry the Cannings couldn't be here tonight. They had a conflict. They do usually attend the Discovery Series. I know many of you are friends with the Cannings, but they were very pleased for us to be sharing this with you tonight. So I want to thank you for being here. I'm Margaret Myer, president of Mcv Foundation. And many of you may have received the brochure that we produced telling the story of Nancy Canning and the experience that she had at VCU. And it's just a wonderful patient story about the resources and the expertise that's available. And we're just really honored to be able to tell a story that's so personal and that's so important to us all about mental health and the fact that it is an illness like other physical illnesses and you can recover from it. And so it's a wonderful story, and we greatly appreciate the Cannings sharing that with us. I want to give you a special welcome tonight to our Discovery Society members. Thank you for supporting one of the units at the or maybe more than one at the MCV campus. We really appreciate your support, and it's the kind of support that you're offering that's making a big difference and helping us to retain wonderful faculty who are being recruited from all over the country, and to attract wonderful faculty and students, and to do the research that makes the difference in saving lives. I want to acknowledge some of our special guests tonight, and I want to start with our team from the Access, Support, and Assistance Program. We call it ASAP. So in the back of the room, and you won't be able to see them with this lighting, but we have Denise Lynch, Cheryl LaCroix, and Sarah Saoud. And thank you, Sound, for being here tonight. So they often serve as the front line to help patients navigate their way through the system and find the right doctor to see and get the right appointment. So we appreciate that so much. And I want to especially thank Denise, who played the piano tonight, and who it was so beautiful, Denise. And I know that we all enjoyed it, and it was very kind of you to offer to do so and to share your talent with us. We launched the Discovery Series 4 years ago, and tonight is our 10th Discovery Series. So I know there's some of you in the room who've been with us through all 10, so thank you so much. And for those of you who are here for the first time, or the second, or the third, or the sixth, we're so happy to have you back, and we have a wonderful program tonight. We started this program to raise awareness in Williamsburg about VCU Health and the wonderful world-class healthcare that's really available to you in Williamsburg just down the street. We wanted to really provide the access to this healthcare for people in this community. And so we thank you for being interested in our story and sharing it with us. We're excited tonight to have the largest crowd we've ever had at one of these Discovery Series events, with over 230 people. So we're happy to see you. It's the kind of event where we want to keep it intimate enough that everyone can really interact with our physicians after the event, but we also want as many people as we can to hear the message that they have to share. So thank you again for coming tonight. A number of the trustees of the Mcv Foundation are here tonight, and I just want to say thank you for being here and recognize them in case that you have an opportunity to meet with some of them later during our strolling supper. Roger Beauvais, Bob Canfield, Charles Crone, Becky Perdue, Judy Starkey, Jim Starkey, Harry Tallheimer, and Gail Johnson are all here tonight. So thank you all for coming. And I want to thank our Williamsburg Host Committee, who helped plan tonight's program. They have helped us plan every single Discovery Series and helped us to reach out to the community to bring people here, and we cannot thank them enough. Julie Baxter and Paul Dresser, Louise and Bob Canfield, Jenny and Charles Crone, Jane and Jim Kaplan, and Judy Starkey. Thank you all so much for helping with another great program tonight. And now it's my pleasure to introduce Peter Buckley. Peter was named Dean of the VCU School of Medicine in 2017. He's the former Dean of the Medical College of Georgia. We're very happy to have him in Virginia now. He is a psychiatrist and an expert in schizophrenia, and he's going to be our MC and host tonight. So, Peter.
Okay, look at those lights come up. Wow. Good evening, everybody. Good evening. It feels a little weird in a funny accent that isn't from Williamsburg to welcome you to your own event. But I share with Margaret Ann and all the colleagues that you'll meet shortly on the panel just our pleasure of being with you. And my wife Leonie is here somewhere. I just can't see with the light. But we are relatively new to this community, and with the support of Judy and with several of you, we felt really warm and welcome to this community. So it's a lot of fun to be here this evening. We've put together a program in many ways in honor of the 10th program, because when we apparently were here at the beginning 4 years ago, we had a kind of potpourri program, a little bit on cardiovascular, a little bit on cancer and other conditions. And so we thought we'd revisit that, but with the unifying theme of imaging. And it seemed like a very good idea. This morning, it seemed like an even better idea. And the reason is, this morning I found myself talking to a group of delegates from Poland. And so it's an unusual crowd to connect with, people from Poland in Richmond. But they were here, and we struck a chord on one particular area, and that is on an extraordinarily famous Polish lady that you will know because it's a TV quiz question, and that is, who discovered X-rays? And it's Dr. Maria Curie. And herself and her husband did so together, and I don't know the background of this, but she got the Nobel Prize twice. He didn't get much, apparently. I'm not sure what happened. But they would, as excited as we are to tell you about the advances in medical imaging, they would be blown away in what has happened over this time period. So we feel that we've made a great journey as a medical community, and we want to share that information with you. The host committee made an important decision when we met a couple of months ago, and that was, let's have something in advance that is like an appetizer. And so our chief medical officer never in his life has been described as an appetizer. But our chief medical officer is Dr. Ron Clark. And he's remarkable for a number of things. One, he is a graduate of William and Mary. He joined our institution in 1997 as chief of staff, and he has been the chief medical officer since 2000, which is a remarkably long time. It's the equivalent, I've already called him an appetizer. I'm now going to call him a school headmaster. It's like the school headmaster of a hospital, because Ron's job is to oversee everything, oversee hundreds of doctors, hundreds of nurses, and make sure that we deliver the high-quality care that several of you had mentioned casually as we were chatting in advance. And Ron is incredibly equipped to do that, and he always has his pulse on what's new and what is the evidence base. And so we're going to begin with just a couple of minutes talking about minutes in medicine. And so Ron, if you'd come up and we'll get started. Thank you. You're going to clap for him, yeah? Okay, sir.
Thank you, Peter, and good evening. It is a pleasure to be back here in Williamsburg, although I really haven't left. My wife was also a member of the tribe, as well as my daughter, times two. Got her law degree here as well as her undergraduate degree, so we love Williamsburg. We're back here all the time, and it's a great place to visit. So I'm an internal medicine physician, and so I order a lot of images, but I have lots of great colleagues here who are going to talk about that tonight. So I'm going to divert from that theme just for a few minutes and talk about something. Dr. Buckley gave me the challenge of, just pick something that'll be of interest to everybody. Okay.
He's going to talk about a rare drug called aspirin.
Aspirin. Yeah. So does, show of hands, anyone know anyone over the age of 70? Okay, so I'm getting there. Has anyone ever heard that maybe you should take a baby aspirin every day? Show of hands. Yeah, okay. Has anyone heard in the last 29, 30 days that maybe you shouldn't take aspirin? Yeah. So an ounce of prevention or not, what's up with aspirin? So it's actually, speaking of William and Mary, when I was a senior here, I did actually a sort of a review on the published literature at that time of aspirin. That's how long this has been around, and longer, because there was a lot of literature at that time. So we're not going to do an exhaustive review of the literature of aspirin. But what I thought I would do is take a couple minutes tonight and talk about what has changed. And don't ask me what you should do, because I'll be my punchline at the end. But anyway. But before we get into that, let's just talk a minute about why we care. you've heard the phrase personalized medicine, and I think it gets a bit overutilized. The reality is, for decades and longer, physicians have been practicing personalized medicine. It's our duty for you to take all the information that's out there and cone it down and crystallize it to what we think is best and right for you. We don't do that just by sitting and gazing into a crystal ball and waving a wand. We really do try to read the literature and understand the evidence that's being produced and how that applies to you. But not only that, some of the great colleagues you're going to hear from tonight, at an academic medical center, it's also our duty to discover that knowledge and to disseminate it. So the discovery, the dissemination, and the practice of clinical care is what we're about, and it's why this, I think, is particularly timely at an evening like this. So this particular study that came out, it really is what we consider as academicians to be important evidence, because it was something called a randomized, double-blinded, placebo-controlled trial, which means they took literally 20,000 people, volunteers. Can't just do it to medical students anymore. And they divided into two groups. So we've got 10,000 here and 10,000 here, and we'll make this group take a baby aspirin every day, and this group won't. But to get into the trial, you had to be, again, a volunteer. You had to be 70 years of age or older, and we're going to follow you for 4.5 years on average and see what happens. So that's basically the study. But again, in our world, that's a well-designed, strong, powerful study to look at a question like this. Because the question was, if these folks who are 70, all these 20,000 people who are 70 or over, to get into the study, you couldn't have coronary artery disease, so blockages in your heart arteries. You could not have cerebral vascular disease, blockages in the neck arteries. You couldn't have dementia, and you couldn't have disability. So these were relatively healthy, functional 70-year-old folks. So what happened? At the end of the 4.5 years of the study, which literally was just published on September 16th, the findings were like this. And remember, this is our aspirin group over here, and this is the non-aspirin. So for every 1,000 people who were followed for a year, one person in the aspirin group didn't have a heart attack or stroke compared to this group. Mm-hmm. So 1,000 people, and for every 1,000, only one avoids a heart attack or stroke. And statistically, that was close, but not close enough to be significant if the statisticians crunched the numbers. In the non-aspirin group, they had fewer bleeds into the gastrointestinal tract and fewer bleeds into the brain. In fact, there were 2 or 3 more of those folks having those kinds of problems in this aspirin group. So one person over here among every 1,000 benefited, but 2 or 3 had a bleeding problem. And surprisingly and worse, and this was really where the study put up a big question mark, we don't know what to make of it, 1 or 2 more in the aspirin group also had a diagnosis of cancer in the 4.5 years that they were followed. Every year they had 1 or 2 more. So if you look at the balance, and the reason this is so important is it's totally tipped the scales in what we used to tell patients was small risk and some benefit. Well, the benefit seems to be pretty small, and there seems to be risk. So that is why all of the churn in the media. So he was going to kick me if I went on too long. So
no, I was just going to kick you anyhow.
Okay, yeah. He's a great boss. So okay, let's put this in the context of the United States. Round number, we have 50 million people in the United States over the age of 70. Let's say 10 million of those would qualify for this study, so they're over 70 and they're relatively healthy. If we were to just do this broadly across the country and put people on aspirin, we might prevent 10,000 heart attacks and strokes and deaths from that a year. That's a pretty big number. But we would cause an additional 20 to 30,000 bleeds into the belly or brain every year, and we might have 10,000 more deaths per year from cancer. So what do? take 2 aspirin and call your doctor in the morning.
Good job. Nice job. We'll have the opportunity to debate all of that round about 11:15 this evening when our panel are finished. I think we'll have our colleagues on the panel come up, and then we'll get the opportunity to introduce each of you. Come on up. Nice job. Thanks. Okay, are we ready to get started? We can get started now because Roger's come in. Rogers, are we okay to get started? Yes, sir. Thank you. Okay. On the far right, your left here, is Dr. Greg Hundley. And let's go through this again. He got his training at? William at Mary. And then he went to VCU. And he joined us recently from Wake Forest. And he's joined as director of our Pauley Heart Center and director of our cardiac imaging program. And so we're really delighted to have him. And you'll understand shortly why we're so delighted. Also recently joined about a year and a half ago is Dr. Sara Temkin. And Sarah's director of gynecological oncology. And she's a remarkably trained colleague and specialist who got her undergraduate training from Cornell and then her MD from Georgetown. And we're very grateful to have her expertise. Thank you. We've already introduced Ron, and Ron got his undergraduate training at William and Mary. On the left, who did not get her undergraduate training at William and Mary, but did at University of Richmond,
Right.
is Dr. Ann Fulcher, who is professor and chair of our Department of Radiology and director of abdominal imaging. And she has been a leader at VCU for the majority of her career and is also a national expert and with her colleagues across the country. And then last but not least is Dr. Patrick Nana-Sinkam, who's professor and chair of pulmonary disease and critical care medicine. And Pat is a graduate of William College.
Close.
And also got his MD degree from Wake Forest. Joined us about just over 2 years ago from Ohio State University, a terrific colleague. This is a wonderful panel of individuals, and I hope you will be both informed as well as enjoy the next 4.5 hours. No, it won't be. So, as we explained, the theme is going to be around imaging, but of course that's very broad, and that's why we have these colleagues. And many of you, I'm sure, have had some imaging experience, so we felt that that also would resonate with people. So Anne, just to kind of get us going, tell us about 2 things. One, kind of what does the field of imaging look like in terms of nuts and bolts of images? Do that in under 45 minutes, that would be
No
great.
problem.
And then secondly, explain for us how we use imaging towards early diagnosis.
Well, first and foremost, it's an absolute pleasure to be here this evening. I want to start by saying that I was not a resident when this machine was being used.
Is that Ron Clark?
No, it's not Ron. And let me tell you why it's not Ron. Ron and I were in the same medical school class. So if it's not me, it's not Ron. So this is a fantastic time to be a physician and a particularly wonderful time to be a radiologist because we do have so much at our disposal. Quite frankly, it wasn't that long ago that our practice really was related just to radiography and then just to angiography. Fortunately, by the time that Ron and I came along, we had a lot more at our disposal. We had ultrasound, CT, MR, Then PET CT came along. Angiography or interventional radiology has absolutely exploded as a specialty of its own. And this has opened up so much, not just for those of us who practice, but those of you, including us, who will benefit from this technology either now or in the future. One of the things that's happened over the years is initially we were always looking at morphology. What is the size of the lymph node? What is the presence of the lymph node? Is the heart big or small? And over the years, we've really transitioned from going from morphology to function. How does the heart work? How does that tumor behave? And did it respond to chemotherapy? And this is a very major shift in everything that we're seeing. Importantly, we're no longer looking at disease at mid and late stages, but we're picking it up very, very early. And to answer your question, Peter, one of the things that we're seeing in radiology, and I'll touch on just a few, is the impact of imaging on early diagnosis and, in some cases, prevention of disease. I know that you're well aware that our practice here, but also nationally, we've been looking at breast disease for a very, very long time. And since the 70s, this has progressed incredibly, such that no longer are we frequently diagnosing diseases of the breast in the late stages, but very much in the early stages. Ductal carcinoma in situ, or stage 0 breast carcinoma, where it is very, very treatable and curable. One of the things that we've seen more recently with mammography in general is that it's transformed from just a few images to what is known as 3D mammography or tomosynthesis. We've been using this at MCV for quite some time now, and it's the equivalent of doing a CT of the breast. So you can really cut through the breast, and even in individuals who have very dense breast, it can very much facilitate our diagnosis of cancer. Compound that with the use of sonography, which allows us to look at the breast in a different way, and then even more recently, MR, which is a great imaging tool for breast imaging. Then follow that up with about 12 or 13 years ago, we were one of the first institutions in the United States to use CT colonography. It has not replaced by any means endoscopy, but it is certainly a good way to go for some patients. Unfortunately, it's not covered by many insurance companies as a screening tool, but it is used extensively in certain other situations where a patient is just not well enough to undergo endoscopy and the attendant sedation that is required. Then coming into our practice about 12 years ago was cardiac MR and CT. And fortunately, we've been fortunate to be able to collaborate with and bring Greg Hundley into our practice with that, and we just look forward to exploding that practice over the years. But what we started with Dr. John Grizzard in our department 12 or 13 years ago is really looking at the heart. And as I alluded to initially, it's not just the morphology, but how does the heart function? And is that bizarre little place in the heart actually a scar, or is it ischemia? So that in itself allows us to really look at the heart in different ways that coronary angiography perhaps may not, and even ultrasound or echocardiography can't. One of the things that we in the Department of Radiology have been so excited about for about the past 10 years is starting a practice in prostate imaging. Obviously, prostate diseases, particularly carcinoma and benign prostatic hypertrophy, affect many, many men. And we look at this as an opportunity to serve that population. What we found with MR through our expert, Dr. Jensen Yu, and now more recently, someone who joined us, Sarah Winks, is that we can use this technology not only to detect prostate carcinoma, but to differentiate the types of carcinoma that require treatment from those that do not require treatment. And this is so beneficial to so many patients. For many, many years, so many men were treated for prostate carcinoma when it really did not require anything other than surveillance. And we can usually make that distinction with MR. At times, it's supported by a biopsy. And I will add that our department at MCV is one of the few in the United States, perhaps the only one, where we do both the imaging and the biopsy. So our own physicians who make the diagnosis now have that image in their mind. We fuse it, the MR with ultrasound, do the imaging and the biopsy under ultrasound so that it's no longer a blind biopsy as it has been in the past, but now we're knowing exactly where that needle is going. So if it comes back negative for cancer, we are very, very certain that there is no cancer there. So many men now can be simply followed with MR rather than with the more complex repeated ultrasounds and in some cases treated for something that really doesn't need to be treated. Then about 7 years ago, we were able to use lots of our CT technology in collaboration with our colleagues in thoracic surgery and in pulmonology for creating a lung cancer screening program, which was the first in Virginia. This was established in the Department of Radiology by Dr. Mark Parker, and over the years, it has really flourished by our associations with our colleagues in pulmonology as well as in thoracic surgery. Now, so what does this mean? Well, it's a great advent because before we really relied on a chest x-ray, something that might have come from that old machine there. And in order to see a cancer in the periphery of the lung, that's your best chance, it really needs to be about 1 centimeter or so. Problem is, by the time that tumor is 1 centimeter, it is comprised of over 1 billion cells, and some of those cells may no longer be in the tumor, but may have been disseminated throughout the body, creating metastatic disease. Well, in contrast with CT, we are able to see tumors that are tiny, just a few millimeters in size. So certainly this type of scanning is not appropriate for everyone, but for those individuals that fall within a certain age range, who have a long smoking history, or who may still be smoking, it is a very major advantage. Studies have shown that an individual who is a heavy smoker who undergoes a yearly lung cancer screening CT lowers their risk of developing and dying from lung cancer by about 20%. So in answer to your question, lots of technology out there, lots of ways to diagnose disease, but increasingly important by collaborating with our colleagues on this panel and throughout the institution. We as an institution have really led the way in many ways, not only in seeing the disease, but in diagnosing it early and in some instances preventing it altogether.
Terrific, thank you. That was very, very clear. Thank you very much. That's terrific. I'm almost thinking I'll ask the rest of the panel to sit down. That was But let's move to Pat. So also understand that in addition to the investigation, our ability to have state-of-the-art imaging it allows us to attract the kind of expert that then can provide that care as well as do that research. And that's really the journey of attracting a colleague of Pat's stellar and seniority. So Pat, tell us about focusing in on the lungs and the diseases that you do. Tell us about the impact of imaging. Again, focusing on kind of this early detection.
Absolutely. Well, first thing I should say is you're a very difficult act to follow. But I'm going to do my best. But I very much appreciate that overview. So as you heard, I'm a pulmonologist, and I've spent the last 15 years caring for patients who have varying diseases of the lung. Everything from pulmonary fibrosis to COPD to, as you heard, lung cancer as well. And this is a really, really exciting time because what we're really seeing is a revolution in how imaging impacts diagnosis, determining response to therapy, determining which type of therapy a patient should get. When we look at lung disease, we now see more and more that imaging plays a very, very central role in that. One example, as you heard, is in the case of lung cancer. It's important to know that lung cancer is often diagnosed very late in the course of disease. If you look back maybe 15 years, the majority of patients were diagnosed with lung cancer late. Only about 16 to 17% of individuals would be diagnosed early in the course of their disease. And as you can imagine, that has tremendous impact in outcome. It has tremendous impact in options for therapy. Now, with the advent of CT scans, in particular low dosage CT scans, so we're really talking about a CT scan that has maybe 10% of the radiation of a standard CT scan, we can actually identify lung cancers early and impact a patient's outcome. When you look at other diseases, case of COPD. Historically, how is COPD diagnosed? COPD is diagnosed, a patient who perhaps has been a smoker. They come in short of breath. You may have seen these individuals who have the pursed lip breathing. You can tell something is going on with them, or maybe it's more obvious they have their oxygen tank that they're carrying with them. And usually the way they'd be diagnosed is clinically, maybe with pulmonary function tests. Increasingly now we're using imaging with very advanced software to really get a better insight into what's the severity of their disease, what might be their prognosis. And then the last example is pulmonary fibrosis, which can be a devastating disease. For the longest time, pulmonary fibrosis, in particular IPF, was diagnosed by a biopsy. Now, anyone who's had a biopsy of the lung knows that it is a procedure that carries some morbidity. And if at all possible, we want to try to avoid biopsying an individual's lung, particularly a person who may have other comorbidities that would make it higher risk for them. Now, it is routine, and I'm sure Dr. Fulcher would agree, it is routine to diagnose a person with pulmonary fibrosis just with the imaging and a very good thoracic radiologist. We're fortunate in that at VCU we have those types of thoracic radiologists. We have Dr. Mark Parker, who I work with very closely, who is truly amazing, and I wish he were here. I mean, he is truly amazing at helping us make diagnoses without having to biopsy individuals. So we're really at a point right now where this is a revolution, and imaging is central. And when it comes to lung disease, you need imaging and the type of advanced imaging that we have at VCU to really make diagnoses and impact the lives of patients.
Great, thank you. Now I understand beside the, thank you, yes please do. Beside the lungs is the heart, and so we're going to talk a little bit about the heart and MRI imaging, and tell us how imaging has transformed cardiac care.
Right. So just in general, for the cardiovascular system, just as Anne has discussed a little bit, and first thing, one point I want to make, I think something, before we get into that discussion, that's very unique at VCU is cardiologists and radiologists working together. In medical school, there's a little bit of a separation, and we all have different specialties and things. One of the outstanding features of our medical center is the expertise that you bring together from the different subspecialties working together. If an image is made of the heart, the vascular system, the lungs, etc., groups working together to make that diagnosis and then to deliver the therapy. So switching over a little bit, and I just want to thank and commend Anne, Peter, all of those in the medical center that make that possible. The next thing that Peter asked about was how do we use imaging in assessment of cardiovascular disease? And if we go back 40 years ago, most of that was done with techniques that deliver what I call ionizing radiation or X-rays. You've heard of that today as heart catheterization. And so generally what we've done is place catheters in veins or arteries in the legs, and now more commonly in the arms. And we administer contrast materials, take X-ray images, and nicely we can identify the anatomy. But it's a little bit difficult to go beyond that. And so non-invasive imaging sort of came around with nuclear radioisotope imaging, where we withdraw some blood, mix it with a radioisotope, re-inject it, make images that way to look at, for example, perfusion of the heart muscle. If an artery would be blocked, a perfusion defect may manifest during a stress test. And so we would look for those non-invasively, so not everybody with chest pain symptoms would have to have a heart catheterization. But that also used ionizing radiation. And so about 35 or 40 years ago, we started developing ultrasound for use. Now, ultrasound is sound waves, and that was a very nice technique for looking at function of the heart. How well does the heart contract and relax? How are the valves working in the heart for those that may have valve disease? Then, maybe 20 years ago, 15, we started thinking about using magnetic resonance imaging for the heart. Now, that was tricky because many of you know, watching sports on TV, knee gets blown out, what do? You get an MRI. Someone has a cerebrovascular event, we get an MRI. Both of those are still. You're not moving at all. Well, to adapt MRI for the heart, we had to count for the heart beating and breathing in and out. And so engineers, again, the team approach, started working on that problem and coordinating the picture taking with the EKG signal. And in doing that, we're able to capture the motion of the heart and look at function. It's almost as if we have high definition television of the inside. But more importantly, in addition to looking at the function and the anatomy, you could also look at the perfusion. That's what the nuclear test did. You can also look at metabolism. What is the heart using as an energy substrate? So with magnetic resonance imaging, probably one of the big advances in imaging in cardiovascular disease is adapting a technology that doesn't use X-rays, no ionizing radiation, and can look at multiple aspects of a disease process: anatomy, structure, function, perfusion, metabolism, with a single test, so we don't need so many tests. And as we're starting to learn, in people that can't exercise, maybe it's not always the heart muscle per se. It could be the blood vessels. It could be the skeletal muscle. And so this technology can do all of the structure, function, anatomy, perfusion in the heart, but also look at it in other parts of the cardiovascular system, that highway, all those blood vessels that are throughout. So I think that is kind of our biggest advancements in imaging in cardiovascular disease.
Okay. I think he deserves it. Cool. So both Pat and Anne talked about using imaging for early assessment and diagnosis, but that's obviously in people that are awake. Sara does amazing work in using imaging in the middle of operations, which is really quite extraordinary. So tell us about that.
Well, so I was going to talk a little bit before I talk about that, about what is a gynecologic oncologist, because I think oftentimes people are a little confused.
What is a gynecological oncologist?
But there are actually fewer than 1,000 gynecologic oncologists in the country, and we're a very small but broad subfield of providers, and we do both surgery and medical care for women with ovarian, uterine, and cervical cancer. And so because the field, unlike other surgical fields, came out of OBGYN, we take our patient care pretty seriously, and we think of the patient as hours from the start of their journey with cancer until the end of their journey with cancer, and hopefully surviving, and sometimes patients don't do as well. But so because of that, we really are experts in both the surgical treatment of our diseases and also providing chemotherapy for our diseases, which lets us do a lot of work with Anne, where we watch how patients' tumors change over time when we give chemotherapy. But what I was going to talk about a little bit more on this panel was also how we've used imaging in the operating room. For example, something called laparoscopy was really quite new when I was training, when I was a resident. You know, we would do kind of little procedures with the laparoscope, maybe poke around. You know, today in the operating room we have instruments that both coagulate or burn tissue and cut, and that was really did not exist when I learned how to do it. So, and now we use those tools really routinely, which has been amazing for patients. The main cancer that we take care of is endometrial cancer, which is the most common cancer amongst women in the female reproductive tract. And one of the things that we used to do was take every single lymph node out of somebody's pelvis at the same time as a hysterectomy. And there's been two real advances that have changed that. First of all, patients almost always come in the hospital, have a hysterectomy, and go home for their whole big cancer surgery the next day. We hardly keep people overnight, more than that one night, because of the advances in not just laparoscopy, but also robotics, which have really let us see in the operating room in this way that's greater than what the human eye can see even. And so the picture that I pulled as my image is what some of the newer technology is, which is something called indocyanine green, and these are this is a green dye that we inject before we start the procedure, and then with a fluorescent camera we can identify what we call the sentinel lymph node, which is the first lymph node that drains the blood supply from the uterus, and this has been used for many years in the breast and in breast surgery, but it was always a little bit of a conundrum. How do I get to the lymph nodes in the pelvis, and how do I figure out a way to identify that in that closed space and with laparoscopy? So we have these really cool new cameras that let us find the hot green lymph node, so the patient can just have one lymph node taken out instead of having the morbidity or the extra surgery of having all the lymph nodes taken out, which can lead to some long-term complications. And so I think that's the main imaging thing that we've been really excited about in the last few years.
Great, thank you. Yeah. Thank you very much. Back over to you. You mentioned about early diagnosis and imaging impacting early diagnosis. You gave us a flavor of kind of the impact of that in picking up lung cancer earlier, but now tell us about the impact in actual treatment of lung cancer.
Sure, absolutely. So it's really important to first put this in context, in that if you look back just 15 years on how lung cancer was diagnosed and treated, what you will see is that there was not much in the way of variety for how you would diagnose lung cancer and how you would treat it. In fact, there was no such thing as early diagnosis of lung cancer 15 years ago. And when it came to therapy, everyone got pretty much the same type of treatment. They would get chemotherapy and radiation, and maybe surgery if that cancer had been diagnosed early, or at an early enough stage. What we see now is that everything is changing. We talked a little bit about early diagnosis with CT scan, but there are a couple of limitations with that. So you can imagine that if you take a large group of individuals and you put them through a CAT scanner, you're going to find some abnormalities in a certain percentage of them, and most of those abnormalities are not going to be cancer. So when we look, for example, at high-risk smokers, 1 out of every 4 of those individuals will have a spot on the lung. So you can imagine how disconcerting that is to a patient to be told that they have a spot. So what I often will tell a patient before they even have the CT scan is, there's a 1 out of 4 chance that you're going to have a spot. What's the second piece of information? 96.3, to be exact, % of those spots are determined to not be cancer, right? It's what we call a false positive, or I tell some of my patients, a false alarm, right? So how do we go about figuring out who's in that 3.7%, where they have a spot that might be cancer? That is where more advanced imaging can now come in. We now know that with much more advanced software that we can look at a spot, and Dr. Fulcher's team can look at a spot and look at not only the size, but the shape, the texture, the morphology, and start to determine whether or not that spot has an aggressive nature to it, okay? So we have advanced imaging. But what we also have, which we may talk a little bit later, but I'll mention now, is we also have more blood tests for diagnosing lung cancer. How many in the room are aware that there are now FDA-approved blood tests for lung cancer? Not many, right? There are about a dozen blood tests in development, and there are actually a handful that are being used in practice at this time. I'll give you one such example. There's a new blood test that was just developed and published in a very high impact journal just in the last few weeks. And with this blood test, it's only 2 markers, so they're not looking at many markers, just 2 markers in the blood. They can actually exclude a lung cancer in a patient with a spot on the lung with about 98% accuracy. So when you start to think about integrating imaging and blood tests, you can see how we are moving at light speed, quite frankly, in terms of making better diagnoses. What's on the horizon? I have a colleague who has been working in this area for the last 10 years now, and very soon he will have on the market an actual nasal brushing where you can just take a little brushing of the inside of the nose, non-invasive, not painful at all, and actually determine whether or not a spot on the lung is cancer or not. This is the direction that the field is moving in. But how do you do that? You do that only through collaboration through several specialists. This is not something that's done with one specialist. You need radiology, you need pulmonology, you need pathology, you need biostatisticians to really accomplish that.
Wow, fantastic. Tell me, Sara, please do clap. Thank you. Sara, you showed images and you showed us the dye, but tell us also how imaging is impacting your ability to treat and differentiate one treatment from another.
Well, just to pick up on what Pat was saying, we use imaging a lot for diagnosis, and one of the main other type of cancer that I take care of besides endometrial cancer is ovarian cancer. And there's never been a good screening test for ovarian cancer. It has been called a silent killer just because people don't know that they even have a problem, and then women go to a doctor and another doctor, and 3 months later they have advanced disease really without ever having a symptom. And what we know is that some of our traditional ways of screening for ovarian cancer have been very unsuccessful, and that's with ultrasound. And there have been at least 5 very big studies that have looked at using ultrasound to diagnose ovarian cancer. But what people have been doing in the last few years and really thinking about is very similar to what Pat's talking about in lung cancer, is using blood tests and using brushings and using our molecular advances to be able to test whether somebody's at risk for ovarian cancer. And that's both through knowing what your predisposition is through your blood tests. If you have something called a BRCA gene, then maybe an ultrasound does make sense. And if you don't, then it probably doesn't make sense. And also using molecular techniques to look. There's a robotic brush that is in development from a real small company that puts brushes into the fallopian tubes of women at high risk for ovarian cancer and takes those specimens back and then says, do you have a P53 mutation, which is one of the first things that goes awry in the fallopian tubes or the ovaries when someone's going to develop ovarian cancer. So I think it's like above the diaphragm, below the diaphragm divide, but we're kind of thinking about the same sorts of ways to move forward, and how do we detect cancer early.
Fantastic. Thank you. Greg, you described clearly the impact of imaging on cardiology, but you're a cardiology oncologist, is that right? Or tell us about the field of cardio-oncology.
Right, so what's emerging, listening to all the presenters up here, is how successful we're starting to be in diagnosing and treating cancer. In fact, morbidity and mortality from many forms of cancer is really declining. So what is this cardio-oncology? What we're starting to notice is that some of the treatments that are implemented actually promote and accelerate cardiovascular disease. So, for example, today, for women not with stage 4 or not stage 0, So stage 0 breast cancer is ductal carcinoma in situ. Stage 4 is metastatic disease. So between that, we have stage 1, 2, and 3. Lump in the breast. It's identified with Ann's mammography technique, ultrasound, or MR. Has a surgical excision, removes the cancer, then needs adjuvant chemotherapy to try and reduce the chance that an undetected metastasis will grow and flourish. What then is done? Administration of chemotherapy and then also local radiation. Well, the heart and the vascular system, what are we generally trying to do with those therapies? We've got to attack the cancer at they're highly metabolic cells. They divide all the time. We can't stop it. What other organ in the body has high metabolism? The heart. It's always beating. It never stops, even when we sleep. What would be susceptible to something that's attacking the metabolism? The heart. What else do we do to get rid of those cancers? We attack the cancer's blood supply, all the small vessels, all the majority of what we have inside of us. The largest part of the cardiovascular system is all the blood vessels. They can become damaged. Accelerated atherosclerosis. That promotes blockages in the arteries go into the heart muscle, heart attacks to the head, strokes. In fact, for stage 1, 2, and 3 breast cancer, after initiating treatment, the primary cause of death is not the breast cancer, which it used to be. It's not developing another cancer. It's now a cardiovascular event, a heart attack, or a stroke. And we're starting to see this theme recurrent across many cancers. Lymphoma, cancer of the lymph nodes, some of the leukemias. When we went to medical school, 1, 2, 3, here at MCV, one of the toughest services to be on was pediatric cancer and leukemia. 98% mortality in 3 months. It took a special person to realize that every day was a gift. Today, 92% cure rate. But when that child gets to be 40, they have a risk of cardiovascular disease similar to someone that's 80 with history of smoking, hypertension, diabetes, etc. So this field of cardio-oncology is trying to identify who might be developing cardiovascular disease as a result of the treatment for cancer and intervene early. And we have therapies that can. I have some images. Is there any way to bring those up? Would it be okay to show those?
Please do.
Right. So we've been talking about magnetic resonance imaging, and I'm going to step behind the chair.
Don't fall off the stage,
right?
please.
I'll get you.
And remember, we talked about high-definition television of the inside of you. And so remember, mammals have 4 chambers of the heart. So right atrium, left atrium, right ventricle, left ventricle. And on these magnetic resonance images, I don't know if you guys can see, the moving blood provides its contrast. So no contrast has to be administered. The heart muscle is the gray, and we can see that contracting nicely. We can slice across this picture like this, and we get what's called a short axis view. And so this is the main pumping chamber, that left ventricle. The gray is the heart muscle contracting. The white is the blood pool. This big chamber here is the right ventricle. It's got a thinner wall because its job is just to take the blood from the body and push it next door to the lungs. So let's look at, now, we're going to become expert readers. So let's go back one. I want you to notice this normal wall motion. Okay, you can see all the thickening of the heart muscle. You can see the thickening up here. So let's go to the next slide. So here's someone that's 57, And they're presenting and they're short of breath. They undergo the ultrasound test, so an echo. And remember, that's a sound wave test. It's really good for looking at function. And it has the 4 chambers, the right atrium, the right ventricle, the left atrium, the left ventricle. And what we can see is these 2 chambers are really large. They should be much smaller than those. And the function is not quite as crisp. But we don't know why the function is reduced. We know it's reduced, but we don't know why. So they come over to an MRI exam here. There's your 4-chamber again. So here are the 2 atria, right atrium, right ventricle, left atrium, left ventricle. All this white in here, this is fluid that's all inside the lungs. It's called a pleural effusion. The contraction is not as brisk, and these chambers are dilated. But why? Well, we come down here, and we do a tissue characterization. We get the why. And in this type of image, this left ventricle heart muscle should all be dark black. But you see this white ring. And what that was, that's an amyloid protein. And this particular individual had a form of cancer in the bone marrow called multiple myeloma. And it's first picked up by, we find this. Let's look at the next case. Next slide. No? Oh, okay. We can get others. So an example of, in cardio-oncology, why is there a merging of some of the imaging and the field? Is we're having patients with cancer develop heart problems. And this is an illustration of magnetic resonance imaging showing the high-definition TV, so we have clarity on the function, but then answering the why as to why the function is abnormal. And that's sort of its beauty there.
Great.
All without ionizing radiation.
Great, thank you.
Yep.
So Anne, you oversee all of these imaging capabilities. It must be both challenging and also this is expensive, this technical, keeping up with this innovation. Tell us kind of how you juggle all that.
Well, I think one of the things to recognize is, as we've talked about, is the importance of imaging and generating a great imaging examination. And as Dean Buckley said, it is very expensive. The equipment we use is inordinately expensive. But to really generate a great imaging examination, in my opinion, requires 3 things. One is a radiologist who is very specific to that area of the body. And at MCV, what we've long done in our department is we only have neuroradiologists reading head, neck, and spine. We only have chest or cardiothoracic radiologists reading lung and cardiac. We only have abdominal radiologists reading the abdomen, musculoskeletal radiologists, the joints, and so on. So that is very, very important. However, the second really important component of a great imaging examination is the equipment. And the equipment is very, very expensive. Now, with that said, the equipment often pays for itself in a relatively short period of time. But I think it's our collaboration and the good relationship that we have with the hospital and our own track record of showing we can use this equipment really, really well that has really encouraged the hospital to work with us and to be an incredible partner. Right now, for example, we're in the process of installing 5 new MRs. Wow. And we have the top of the line equipment throughout the department. Same with CT scanners. We're opening a new imaging center in the Gateway building. All of our ultrasound equipment, for the most part, is new. Same with mammography. And that's one of the things with radiology. You really have to stay on the cutting edge with these machines. So it's one thing to have a great radiologist, but you have to couple that radiologist with outstanding imaging equipment. And I cannot say enough good things about our hospital for investing in that equipment. As Dr. Buckley said, yes, it is expensive, but in the long run, arriving at a diagnosis sooner pays back in dividends, not just financially, but in the life of that patient and in the productivity of the institution. Now, as I said, there were 3 things that result in a great imaging examination. One is the radiologist, the second is the equipment, but the third are these individuals that are sitting around us, because it is so meaningful for a radiologist to have individuals such as these with whom we can collaborate and speak the same language. That results in a better diagnosis for everyone. And I'll just put a plug in here for our academic medical center, but also for all academic medical centers. We at these centers make a special effort to have what we call multidisciplinary conferences. So Patrick, along with Mark Parker, and the thoracic surgeons get together, and they talk about imaging, but also other forms of diagnosis in patients, in specific patients, and together chart out a treatment plan. The same with Sara. We both participate in a gynecologic oncology conference that includes not just us, but residents, medical students, folks from radiation oncology and pathology, and everybody kind of gets together and puts their heads together to figure this out. So part of it is truly the reader. Part of it is the fantastic imaging equipment that we've been able to get from our hospital administration. And then the third part is just the partnership and the collaboration that you have with your colleagues. And I cannot underscore that third component enough.
Okay, great. As a academic CMO, how does imaging fit then in the role of an academic medical center compared to other institutions?
So I'm glad you asked. One of the issues...
I told you I was going to ask you that.
So Anne started the theme, and I'll continue it, because one of the issues, quite frankly, we're facing in healthcare today is the pressure to deliver value in healthcare delivery. So, value is quality divided by cost. So if the cost is high in that equation, your value is diminished. And so how do we keep things in balance so we're delivering better health to the Commonwealth of Virginia, better value for the billions of dollars that are spent in the Commonwealth. So a lot of pressures to do that. Some of those pressures, quite frankly, are to have folks go to the friendly imaging center on the corner and just get your CT scan over there and ship us the CD or the pictures through the internet, and we'll just take a look at them. Mm-hmm. To be honest with you, I would have to say today that in the big scheme of things, we might save a nickel, but it's going to cost us down the road, because now we've got someone, now all CT scanners are created equally. Images are not all equivalent. We have to get those, bring them into our system. They might not have done them the way we needed to get the exact cuts that we were looking for. Maybe they didn't carry them down far enough into the adrenal glands when we're looking at the pulmonary images. So having that teamwork together and having the imaging integrated is critical. So a lot of pressures out there to disintegrate this care. And for me, as a chief medical officer, one of the reason I come to work every day and have for the last 20-some years to do this is because we are making advances in the quality of care. We are delivering great value. We are finding ways to, back to the prostate example, to not do things that are clearly harmful and don't improve quality or quantity of life. And yet there again, we've got major issues going on with who's going to pay for what, because we're being short-sighted in the view of things instead of taking the long-term picture. So it's something that's timely and we're addressing every day, but it's to me it's about the team working collaboratively to deliver great value.
Okay, great, thank you. Pat, let me ask you, you talked earlier about integrating blood tests, biomarkers with imaging. Tell us a little more about that, and then also you've been doing radiogenomics, is that right?
Absolutely,
Yes,
absolutely. So, as I mentioned at the beginning, we're really going through a transformational times in terms of diagnoses of many lung diseases. And I was alluding earlier to the fact that now more and more we're integrating imaging with blood-based testing and other types of assays. But speaking to Dr. Clark's point, one of the issues we have to be aware of is we have to be cost conscious in how we do this, because we simply can't order all of these types of tests on every single patient. And it speaks to a really important point, and something that has, I think, come to the forefront as we've been moving along in this field of diagnostics, and that is we have to be much smarter about risk stratification. And lung cancer is a classic case where risk stratification is necessary. So when you think about the fact that we screen patients for lung cancer, and we really screen those individuals based on only really 2 criteria, their age and their smoking history. Now, many of you in the audience know of individuals who smoked their whole life, never got lung cancer. But just conversely, you know of individuals who maybe never smoked and got lung cancer, or stopped smoking even 30 years ago, right? So what we recognize increasingly is that we have to be better about risk stratification, and that there are many other factors that we have to consider when we actually diagnose an individual. So how do we go about doing that? One area that has really emerged is what we call radiogenomics. Radiogenomics provides us some very interesting insight. What we're essentially doing in radiogenomics is we are linking imaging with gene expression, looking at the genes that a person has, say, for example, in a tumor. You have the picture, but the picture may not necessarily tell you whether or not this is an aggressive tumor, whether or not it's a tumor that will respond to therapy, whether or not it's a tumor at all. So what investigators have done over the last several years is they've started to link the imaging to what's actually in the tumor. And over time have been able to develop what we call algorithms, where a member of Dr. Fulcher's team can look at a tumor and say, well, we already know from previous studies that a tumor that looks this way has this type of expression in its genes. So you can imagine that we're moving further along, where we get to a point where the imaging will tell us much of what we need, right? That is a case where we can make a diagnosis without having to do additional testing. That's an example of radiogenomics. One other example that I want to give of radiogenomics. I mentioned earlier that 15 years ago, everyone got pretty much the same type of chemotherapy and radiation and maybe surgery. Leap forward 15 years. Now we have over a dozen, and we are rapidly moving towards 24 types of mutations within lung cancer where we have a drug that can target that mutation. There's a very interesting study that was just published in the last couple of months, where investigators linked the imaging of a tumor, what it looked like on a scan, with what type of mutation there was. And through using what we call machine learning, sometimes people talk about artificial intelligence, right? They were able to eventually come up with an algorithm where, based on the imaging, they can predict what the mutation is. That is without the biopsy. You can tell what the mutation is, so then target the therapy. Those are 2 such examples of radiogenomics.
Now, you mentioned artificial imaging.
Artificial intelligence.
Artificial intelligence.
Yes.
And so this seems very ripe for that, Anne. Is that? Tell us about how that's going to, because the eye can only see so far,
Right.
and you have so much information.
You're absolutely right. I think artificial intelligence will help us immensely. In part, as Patrick had mentioned, that's certainly one way. In some areas, we've been using it for many years. Computer-assisted diagnosis
Right.
in mammography, and it's sometimes for some individuals on chest CTs even. But I think it's going to be nothing that we should worry about losing our jobs. I do think that comes up sometimes.
I'm not worried about losing my job until you said that.
But I think it's really something that can help us all. Some with very important associations, as Patrick pointed out, and in some areas, something a bit more mundane. We spend a lot of our time measuring nodes, measuring areas in the liver. And if we can have some type of automated way to do that, all the better. because what that does is it frees the radiologist up to really converse with our colleagues, to think about new things, rather than simply doing these kind of technical measurements that often slow us down and, quite frankly, are not that intriguing to most radiologists. The other thing that artificial intelligence can do is really help our physicians, unlike these folks, but people who don't have the experience and expertise as these individuals, order the right examination. And that is something that's going to be in place at MCV as well as other institutions very, very soon. A clinical decision support. So for example, you order a CT and the patient has such and such listed as a diagnosis, maybe pneumonia or a lung nodule, and it really reports back to that individual, is this the best test for this, according to guidelines set forth by the American College of Radiology or the American College of Cardiology and different societies. So I do think artificial intelligence will play a great role in assisting us, but I don't think anything will ever replace a physician's mind and a group of talented individuals working together as a team for the betterment of the patient.
Okay, great. Thank you. Sara, tell us about your work on molecular imaging.
So I think of molecular imaging really when I think about what the future is going to be for drug development, and also right now what we do when we give some of the targeted therapies that Pat is talking about. You know, ovarian cancer, for example, is one of the most heterogeneous cancers in terms of the number and breadth of mutations that they contain. And so we've been, depending on what the mutations are within the cancer, we may give a specific type of drug. And so what I think the future of imaging is that you can give the right drug to the right patient at the right time and then measure whether that is actually hitting the target through imaging with special contrast materials, and be able to say what is really a functional biomarker rather than a predictive biomarker, which is the way that we think of these things. Like, is the drug actually getting to the right place in the patient's body, and is it causing the cancerous cells to die? And I think that's where we're going with molecular imaging, and knowing that the right pathway is being hit, and we're making progress.
So do you think that'll be part of treatment within 5 years, 10 years?
Yeah, I mean, I think right now a lot of those techniques are investigational, and I would be hopeful that, you know, in the next 5 to 10 years we have those capabilities for certain drugs.
Okay, so let's ask the remainder of our colleagues to speculate in their areas where things will be 5 to 10 years from now. So let's start with you, Greg, in terms of imaging and where you see that 5, 10 years from now.
I'm glad you're starting.
I know. I think there'll be a little bit more automation, and it will enhance speed. So those pictures that I showed, about 25 years ago, we got started in this. And to do a heart study, you need about at least a minimum of 10 of those pictures. So to get one of those pictures, you would scan for 10 minutes. So you need about an hour or so. And at the time, so I was in my training, and I was not a coffee drinker, but I was in Texas, and there was this thing called Mountain Dew. And so what I did is I stayed up all night drinking Mountain Dew, figured out a way, the MRI thing was in the basement, ran some wire up through there, played the radio, and typed binary commands. That's zeros and ones in patterns, and you saw those pictures the next day. Today, that whole collage, plus, so the 3 we saw of the normal wall motion, plus 6 more, is all acquired in 10 seconds, and the images come right up.
Wow.
So what does that enable someone to do? We talked about the why. Well, now you can start to put together anatomy, function, perfusion, and you can compact that into 10 minutes. We talked a little bit about moving around the body, the whole body scan. That could be really expensive. But when could that be helpful? So the largest growing syndrome in cardiovascular disease in the world is heart failure. Start to walk, and we become short of breath with walking. We have reduced energy. It's a big problem when it becomes pronounced. For many, we can't perform activities of daily living, can't go grocery shopping. It reduces independence. Not every single person that has heart failure has a problem with the heart muscle function per se. There actually might be an issue with the blood vessels that deliver the blood to the working skeletal muscle. There might be a situation where the heart's pumping okay, the blood vessels are carrying, but the skeletal muscle's not working correctly. So where do I see things moving? We're starting to be able to use that speed and image here, here, and here all at once. And that allows us to do point-of-care testing in patients with heart failure. Make the diagnosis right there so that a cadre of physicians can deliver the correct therapeutic intervention for the reason for that patient's heart failure and treat them. You're not wandering around in that diagnostic milieu of an outpatient visit with your primary care doctor, the cardiologist, the pulmonologist. We know right then and there exactly what it is, and then the outpatient experience can be dedicated toward the therapeutic intervention that helps you the most. So I think probably one of the bigger things, we'll see two in imaging, that'll be one. The second is going to be the breadth of imaging assistance to interventional cardiology. You see that today with percutaneous procedures, catheter-based interventions that are replacing surgical interventions. We started doing that in the coronary arteries in the 1960s, angioplasty, then stents and things like that. But we're going to start to see more of that with valves, not having to have heart surgery for valves. Well, to deliver that correctly, you're going to have to image simultaneously with that procedure. And I think that'll be the second large growth area of the next 5 to 10 years in cardiovascular disease imaging.
Okay, I've got an amazing idea. And that is, after all of this, you will be able to ask the other panelists about 5 or 10 years what things are going to be, because I want to make sure that we leave some general questions. So we're going to kind of short circuit that final question. No, it's good. It's good.
Can I just?
We're going to go to Ron.
Yep.
Yes, Ron.
So I can guarantee you, 5 to 10 years from now, we're going to be debating aspirin. Just saying.
Okay. Molecular imaging of aspirin is on our way. Yeah. Okay.
Aspirin.
So let's take some questions from the audience at this stage. Yes, sir.
As a retired medical oncologist from an academic medical center, I couldn't agree more on the help that is provided by a multidisciplinary tumor conference. We started doing that in the 1980s, and I was amazed at how much difference it made, as opposed to sending patients from one guy to the next, to the next, to the next. My question has to do with what application currently does the PET scan have? It was something that was becoming more and more prominent the time I retired, which was a number of years ago. And I've always wondered about what its current application is.
Great. Anne, do you
Sure.
want to take that?
Well, it has a great deal of application. It kind of gets back to one of my initial points, is that we've really moved in some regards from going from detection of morphologic abnormalities to function. And the way it really helps, I'm an abdominal radiologist, perhaps there's a lymph node in the abdomen or pelvis that's quite large, but that doesn't necessarily mean that it's filled with disease or neoplasm. On the other hand, what we've also found is there could be a tiny lymph node that we would never call abnormal based on size or otherwise appearance, but it really is metabolically active on PET. So it's really opened our eyes up to that, and I think it's allowed us to, in some ways, see what is really functioning there as tumor or not. Obviously, PET is not perfect for every tumor, but it is very, very useful for lymphoma. I know Sara's group uses it for a wide variety of oncologic tumors. Likewise, it can be used in the setting of lung cancer. So I do think it has a lot of applications, and it's a great addition to our imaging tool. As you know, when it first came out, it was just PET. Then it was coupled with a PET CT, which is also very helpful. And more recently, it's coupled with a PET MR, which can be useful in some instances as well.
What is PET?
Yeah.
Positron emission tomography.
That's why it's called PET. It's easier to say the other thing. Okay, another question. Great question, by the way. Another question.
There's one right there.
Yes, sir.
I can understand, and I think everybody agrees, that early detection is obviously great. And I can understand why a woman who gets a mammogram every year, you can find early stages of cancer, probably quite often. But I don't come in for a chest x-ray or a chest examination every year. And I know so many people who have had cancer, and they don't go to the doctor until it's too late because the symptoms aren't that bad. How do you get the early detection in so many of these different diseases?
Pat, do you want to say
So
that?
sure. So I'll just speak to lung cancer because we've been talking about that a little bit this evening. You know, the reality is we know now that there's a certain population of individuals, certain group, 55 to 77 years of age, who have a certain smoking history that we know are considered the higher risk for getting lung cancer. The other point I'll make is that the majority of early stage lung cancer occurs in individuals who do not have symptoms. This is the reason why so many individuals up until now present with lung cancer late in the course of their disease because, as I tell my patients, they wait for a worrisome symptom, a cough that won't go away or unintentional weight loss. We have a responsibility now, particularly with this advent of early detection with CT scan, to educate the public and explain to people that you don't wait until you have symptoms. If we determine that you are a high-risk individual, then you come in and you get your CT scan. I mentioned earlier that the CT scan that is done through Dr. Fulcher's department, this is a low radiation CT scan. This CT scan has less radiation than what you would be exposed to just walking around Richmond for a year. Okay? Not that you would walk around Richmond for the entire year, but you understand what I mean. But the point is that it's very, very low radiation. So we need to be much more vigilant about educating the public, those individuals who we know are high risk, of coming in and getting their CT scan. The other point is that this CT scan takes 10 seconds, right? 10 seconds. And we now have established a program at VCU where the individual can come in and get their CT scan, and we actually give them their results within 15 minutes. So and you do it once a year, and that's it. And once you reach 77 or you've quit smoking for 15 years, you're done. You don't have to be scanned again.
Okay, I think we will. We can obviously continue the discussion to the back room, but I think at this stage we'll close and ask Harry Thalheimer to come up. Harry is the chair of the Mcv Foundation, and he's a tremendous advocate for our institution and for our health system, and he is also one of many of you who have been at all 10 Discovery series, and so you get a half glass of wine at the end of this event. Harry, thank you very much.
To steal Charles Crone's line, it is I who stand between you and drink and dinner. So I'll be mindful of that. Peter, thank you for an outstanding job. Dr. Clark, Dr. Hundley, Dr. Temkin, Dr. Fulcher, Dr. Nana-Sinkam, thank you. I will tell you, and I've said this before, serving as chair of the McV Foundation board has been the highest honor I've had in my life. To work with a group of dedicated volunteers to advance the work that's done at VCU Health on the McV campus and around the Commonwealth. And this is a perfect example of outstanding leaders of medicine and science, collaborating, integrating, and always looking at better ways to take care of patients. And what I think you really have to know is that not only do we take care of people who are fortunate like us, we take care of so many who are not. And that is a challenge and a job, and as a leading trauma center in Central Virginia, it's a busy place. And we don't suffer from a lack of need and a lack of care. And I think, as I'm proud to sit here and see this caliber of professional leadership taking the time out of their day. They all work today. They're all going to work tomorrow morning. Sharing this with you, to me, that gives me something special. So I look forward to being here for the 11th one with the next panel. Thank you all very much. Appreciate it. You know, when you mention a list and name people, you get in trouble, so I do want to apologize. We did leave off Dr. Susan Kornstein as one of our trustees who's here today. Susan, we love you and we admire what you do, and thank you for being here. And also in our audience, somebody who I want to stand up, a lifetime honorary trustee of our board and one of the leaders in the world of cardiology, George Vetrovac. George, please stand up. George, thank you. Many of you may remember when George came here and held up that little plastic heart. I think he brought it with him tonight. In a Target bag, that's exactly right. I want to thank the host committee for your participation and leadership. It's because of you that we've been able to put together a program like this. Margaret Ann gets mad at me that I don't sit in the front row. First of all, I'm too anxious and I can't. But I like to sit in the back and watch you watch them. So I guess in a way that kind of makes me a little bit of a voyeur. But the attention that this crowd pays to what's on stage, to me, gives me great thrills. I don't know if you can tell it from the stage, but it's remarkable. Nobody's racing to get out. And that does bring up an organizational, we're going to make a change tonight. Please do not leave your seats until the panel gets to the back room, because we have stations set up for each doctor. So you don't have to go look for them. You'll see them. There'll be a sign. So you can go find the doc that you want to talk to about whatever it is you want to talk to. And if you just allow them to get out, that would be very helpful. But I want to thank those of you who are here tonight who are members of our Discovery Society. Last year we announced we had 115 in membership. This year we're at 149 and growing, which is amazing. We've got over 230 people here tonight. Think about that. It's terrific. We congratulate you and we thank you. I do want you to know that something that somebody told me a long time ago, that we've got something very special here, and it's proven tonight. As an academic medical center, we do things that your hospitals, neighborhood hospital, your community hospital, your regional hospital doesn't do. We teach it, we live it, we hire the best, we recruit the best, we teach the best, we give the best care, but we do it together in this collaborative, integrated environment. And I will tell you, there's two words that I cannot go to bed at night without thinking about, and that is they do it with compassion and they're committed to quality. And that is what makes us all proud. So doctors, thank you. Peter, thank you for an outstanding job. Thank you all for your support. When you leave tonight, if you're not a member of our Discovery Society, there are folders out front. We'd love for you to grab one. Join us. We'll have another panel of great docs and leaders from the healthcare system here. Brian, when are we doing the next one? Within a year. Thank you, Margaret Ann. And let me close by saying three people that really need to be the unsung heroes that are here tonight. Number one, the McV Foundation staff that do a world-class job putting on an event like this. Two, the staff of Two Rivers. What a great facility and what a great performance. And our technical crew, no flaws. Well done. So with that, I'm done. I'll see you at the 11th. The rest of you, I'll see you on the bus going back to Richmond. Let's give these guys and ladies a round of applause. And if we can let them get to the adjacent room, we'll adjourn for a strolling supper in just a minute. Thank you.